Great, thank you. Welcome, everyone. So I will talk to the very exciting subject of neonatal jaundice and cholestasis, which is a common problem that you'll see in infancy. And so hopefully after this talk, you'll know how to diagnose and manage it, as well as pass these questions on the boards. So starting with bilirubin metabolism, heme is catalyzed by heme oxygenase in the presence of the P450 system. Important things to know about heme oxygenase and heme is that heme oxygenase is an inducible enzyme. It's induced in times of stress. When there's more epinephrine, glucagon in the body, that induces more heme oxygenase, it turns over the heme, you get more bilirubin production. So those are important things to know. Bilirubin, 85% of the bilirubin produced in the body comes from hemoglobin. So that's another important. Other possible sources are like myoglobin or other globins in the body. Bilirubin is then conjugated to two molecules of glucuronide, which come from UDPGA dehydrogenase, and conjugated bilirubin is then excreted into the bile and then into the intestines, where it's transformed into urobilinogen by bacteria. Urobilinogen is then reabsorbed into the body and excreted in the urine. So when you think about jaundice in a newborn period, you first have to determine whether it's a direct or indirect. For purposes of this talk, and even for your boards, direct bilirubin essentially equals conjugated bilirubin. A direct bilirubin of greater than 1.5 milligram percent or greater than 15% of the total bilirubin is abnormal and indicates a conjugated hyperbilirubinemia. Conjugated bilirubin is water-soluble, and unconjugated bilirubin is more lipid-soluble. Water-soluble, so the conjugated, the direct bilirubin, that will help turn your urine darker color because it's excreted in the urine. And the reason why it's important to know about unconjugated bilirubin being more lipid-soluble, that's the reason why it can cross the blood-brain barrier and lead to kernicterus in infancy when the level is too high. So causes of unconjugated hyperbilirubinemia in infants include physiologic jaundice. There's a delay, many reasons for this. There's a delayed conjugation and increased turnover of heme, as well as an immature secretory system within the liver. The bile ducts are just a little bit more sluggish. And then there's an immature excretory system. Those babies are just not passing out their stools as well as you would hope they were. Maybe, the breast milk is not enough fluids, maybe a little dehydrated or but they're just not passing it out of the body. Bilirubin then peaks at about 6 to 12 by day 4 to 6. Usually jaundice appears by day 2 to 3. Maximum level is usually about 15 milligrams per deciliter. The urine is pale because why? The indirect bilirubin, which we see with unconjugated hyperbilirubinemia, is lipid-soluble, not water-soluble, so it doesn't get passed into the kidneys, right? The stools are the normal color because the baby is still conjugating bilirubin in the liver, and that's being excreted, but it's slowed down. That whole production is slower than it should be at that point because of the immature processes within the liver. Other causes for exaggerated physiologic jaundice, which will be potentially a question, would be prematurity. These babies have less bilirubin, less enzymes than a full-term baby. In addition, they're under a lot of stress, so heme oxygenase is induced and at high levels. And lastly, the red blood cell half-life for preemies is shorter. And if you think about the red blood cell mass to total body mass of the baby, the level is much greater than you or I. So all these things predispose them to having an exaggerated physiologic jaundice. Medications that we might use, things like furosemide or antibiotics, may dislodge bilirubin from albumin and make it elevated. Bruising is another source because of hemolysis in the bruise. Inadequate oral intake leading to stress in the baby, leading to induction of heme oxygenase. Delayed stooling, as I said, and breastfeeding. We'll talk about that a little bit more. So into question number 1, a breastfed infant who's 40 days of age has a total bilirubin of 6.2, a normal direct bilirubin. So this is all indirect hyperbilirubinemia or unconjugated. There's a sudden rise to 15, still with a normal direct bilirubin. What is not a possible cause for the increase in indirect bilirubin? So breast milk jaundice, B, sepsis, C, biliary atresia, D, fasting. So C is the correct answer. Breast milk jaundice, even though people may say like, oh, she's 40 days of age, why did it suddenly increase? You'd have to wonder if there was something else going on, the breast supply decreased, resulting in essentially fasting or something like that. But breast milk jaundice could still cause it at that point in time. Sepsis, as a cause for interfering with the liver, and the conjugation and the direct effect of endotoxins in the liver could lead to a rise in the bilirubin. Biliary atresia is the correct answer because that always has a conjugated hyperbilirubinemia associated with it. So this is all indirect bilirubin, so it would be unlikely to be biliary atresia, though it should be high in your mind in your differential when you see a baby with worsening jaundice, especially at 40 days of age. And fasting, as I said, induces hemoxygenase, which can lead to increased bilirubin turnover. Red flags in physiologic jaundice include jaundice within the first 36 hours of life, a total hyperbilirubinemia greater than 12 within the first 24 hours, persistent hyperbilirubinemia after 8 days of age, and elevated conjugated hyperbilirubinemia. So if you have either of those last two, you really should do studies, checking again their total and also getting a direct bilirubin at, essentially 2 weeks of age. If they're still jaundice, I would always check a direct bilirubin because of the risk of biliary atresia. Breast milk jaundice can actually look like physiologic jaundice that slowly gets worse. It becomes apparent after 5 to 6 days of life and may look like it's deepening the physiologic jaundice. It rarely exceeds 20 milligrams per deciliter, can last 6 to 8 weeks, sometimes even a little bit longer, decreases significantly after holding breast milk for 2 to 3 days, but we don't recommend that because we don't want anything to interfere with the mom's breast supply and that whole interaction. So even though that's potentially has historically been a useful test, we really don't recommend it. Lots of thoughts about what the pathophysiology for breast milk jaundice. Is it an unusual metabolite of progesterone in the breast milk? Is there increased concentrations of non-esterified free fatty acids that inhibit hepatic glucuronyl transferase in the infant? Is there increased enterohepatic circulation of bilirubin as a result of the breast milk? And then lastly, I think is an interesting thing, and actually I was just giving a talk somewhere else and we were talking about Gilbert's, and he had told me that this gentleman told me that his child had prolonged jaundice as an infant, and he happened to have Gilbert's. I said, that's classic because we'll talk about Gilbert's a little bit more in a few more slides, but what ends up happening is that there's a decrease in the uridine diphosphoglucuronyl transferase activity in the infant, and that makes them have a more prolonged course of indirect hyperbilirubinemia. And that may be what's happening in breast milk babies as well. The treatment, we would definitely recommend continued breastfeeding and increasing the frequency, trying to get these babies hydrated, trying to increase their stool output, and getting the increased turnover. Phototherapy as indicated, and again, we rarely indicate cessation of breastfeeding because of the difficulties restarting breast milk and et cetera. So question 2, early feeding in a neonatal period does all of the following except slows down the intestinal motility, B, promotes the development of a normal bacterial flora, C, improves the evacuation of meconium, D, increases the amount of uridine diphosphoglucuronic acid. Say that 3 times fast. And the majority of you have gotten that correct. It does not usually slow down the intestinal motility. It usually increases it because of a volume load. One of the good things about feeding a baby is that they will develop the normal bacterial flora, which is probably also one of those problems in premature infants when they may be on IV fluids and may not be being fed. enterally, and so their normal flora is not being produced or not being developed. And again, feeding improves evacuation of meconium and does increase the amount of uridine diphosphoglucuronic acid because it's and you need nutrition to do that. Other causes of unconjugated hyperbilirubinemia include hemolytic anemia, where you get the production of breakdown of heme. Heme also is an inducer of heme oxygenase, so it becomes a vicious cycle with increased production and increased induction. So it usually occurs within the first 36 hours, so a little bit of a red flag there. Normal colored urine, because this is mostly indirect bilirubin. You may have signs of hydrops fatalis or hepatosplenomegaly, and a peripheral smear is going to show numerous erythroblasts, so you always should order a peripheral smear to be looked at by your pathologist. Causes include blood group incompatibility, hereditary hemolytic syndromes, neonatal infections of bacterial or viral origin. So all of those things can lead to increased hemolysis. One of the most important and worrisome causes of indirect hyperbilirubinemia in infants, but pretty rare, is something called Crigler-Najjar syndrome. There are two types, 1 and 2. It's due to the absence of UDP, glucuronyl transferase, presents very soon after birth with a very rapid rise in the bilirubin. It's all indirect. Their urine is light because indirect bilirubin is not water soluble, so it doesn't get into the urine. Their stools are sort of grayish in color. They are not really conjugating their bilirubin, so they are not getting bilirubin into their stools to turn it a nice yellow-green color. Excuse me. Kernicterus frequently occurs. Type 2 frequently will respond somewhat to phenobarbital, but these children, when born with this disorder, will require lifelong phototherapy. So if you can imagine what a lifestyle, quality of life issue this is for them. Initially as school-age children, they can probably deal with that at home, be under the phototherapy. They have to go to bed at night laying there without sheets, with photo banks over on top of them, light sources over on top of them. And then we can imagine how do you go to college with that, and then when you develop a significant other and nobody wants to be under those lights all night long, and so it's really awful. This is one of the few diseases where the liver is actually very, very normal. It's doing everything it should be, except it lacks this enzyme, and we will transplant these children because of that awful quality of life that they have. So question 3, have a 10-week-old so a little bit older, brought into the office by the mother, notes that the baby appears jaundice. At 3 weeks, had a total bilirubin of 8.2 with a normal direct bilirubin. The baby is otherwise well, light-colored urine, green stools. Is this still within the realm of okay for a breastfed baby? Yes, A, B, no. I'm actually glad to see a mix. Generally, I would say yes, it could be, but not without further testing. So you really would need to make sure at 3 weeks she had a total and direct bilirubin. I would definitely get another total and direct bilirubin on the baby at this point in time, even if there are light urine and green stools, because even with biliary atresia, sometimes the stools can be intermittently green. And without seeing the stools yourself, I hate to say this, don't trust the mother. Because I have had parents tell me like, oh yes, the stools are green. And I will even show them color pictures and oh yeah, they're that green. If I don't see them myself, I really don't trust it. So I would literally do Dr. Mahajan talked about doing a digital exam on anybody who walks in, you're worried about an IBD. I would do a digital exam to try to stimulate some stool production so I could see it visually myself to see what that stool looks like. Because so many times the baby will pass an acholic stool. What is the color of acholic stool? Well, it's probably a little bit lighter than those tablecloths that you have. They look a little beigey to me. So an acholic stool would sort of be creamy beige color. And the baby will pass the stool, and I'll say to the mom, like, is this what they normally look like? Oh yeah, nice and green. I'm like, You know, so, and honestly, it's happened over and over again. And nowadays with cell phones, I actually give the moms my cell phone number, and you can't imagine all the pictures of poop I have on my phone. Is this okay? You know, so I'm trusting that they don't use it for other things too, but anyways. So in that particular case, that baby might have had Gilbert's because it was a prolonged indirect hyperbilirubinemia. Often there's a family history, so you could ask that in the family. Does mom or dad get a little jaundice under times of stress? Is there anybody in the family diagnosed with Gilbert's? It's due to a deficiency, but not a complete absence of UDP glucuronyl transferase, which is the same enzyme that is missing in Crigler-Najjar. So this is sort of a very mild form of it. There are no other bad things that happen with with Gilbert's syndrome. It just makes you a little jaundiced, especially under times of stress. More common in males than females. It's autosomal dominant, but incomplete penetrance, so you could have multiple family members not have it, but a great-great-grandfather had it, and now all of a sudden the son has it. There's usually a normal physical exam, normal enzymes. If for some reason somebody did liver biopsy, which I don't recommend, then the liver biopsy would be normal. Other causes of neonatal unconjugated hyperbilirubinemia because of obstruction and also because of dehydration, etc., are pyloric stenosis, hypothyroidism, and any other causes of stress. So let's talk about cholestasis, kind of the really worrisome thing that we see as well. Neonatal cholestasis, just to reiterate, is when a conjugated bilirubin is greater than 1.5 milligrams per deciliter, or it's over 15% of the total bilirubin concentration. This is most important if the bilirubin is still relatively low. Say the bilirubin is 5 milligrams per deciliter, but the direct bilirubin is 1. You might say to me, like, well, you said it's not greater than 1.5 milligrams per deciliter, but it's greater than that 15%. So that would be worrisome in that particular infant. A neonate may not appear jaundiced till the bilirubin is over 5 milligrams per deciliter. In older children, it might be noticeable at a lower level. Most present within the first month of life, and consider in any neonate jaundice greater than 2 to 3 weeks of age. So again, jaundice at 2 to 3 weeks, what are you going to get? You're going to get a total and direct bilirubin absolutely at that point in time. Important things in the history and physical that you can help lead to a diagnosis. Were there any complications of pregnancy? Was the mom on any medications during the pregnancy, especially the last trimester? What was the neonatal course like, especially if it was a preemie? Did they need TPN? Did they have sepsis? Do they have any other anatomic abnormalities? Is there a family history of jaundice or early deaths in babies from previous pregnancies or in the family? Looking at the growth, are they gaining and growing well? Are there any cardiovascular findings on physical exam? Murmurs like pulmonic stenosis. So it's important to listen not just to the front for murmurs, but to the back as well for murmurs. Hepatosplenomegaly, and always when you're looking for hepatosplenomegaly, also look in the midline because some of these babies have abnormal livers and abnormal placement of the liver with something called a midline liver, and the liver may be down below the xiphoid process several centimeters, and you may not realize it's there because you're feeling over the right upper quadrant below the vertebrae below the ribs, and or in the left upper quadrant looking for a spleen. Also feel in the midline as well. You want to look for other extrahepatic anomalies like your extremities. Are there any abnormalities with them? And also, like I said, check the stool color. If you can't get it in the exam, when you see the baby, have the mom send you a picture of it one way or the other. Fractionate the bilirubin. It's really important to get that direct bilirubin. Looking for liver injury tests. Notice I didn't say liver function because really functional tests are different. Liver injury tests include the enzymes ALT and AST. Both of those enzymes are released when liver cells are broken down, and they release these enzymes. The alkaline phosphatase and the gamma GGT are released. They're actually induced enzymes that are released with biliary obstruction. So those arise if there's sluggishness in the bile ducts or if there's an obstructive process. Liver function test, because the liver is a factory, that's its primary function, needs to make all sorts of proteins, and it makes coagulation factors that are important to your PT. You can actually measure factors if that was thought to be necessary. You can look at albumin, but remember, in a preemie, your albumin is probably going to be low. The albumin half-life in an adult is about 27 days, 25 to 7 days. In infants, it's a little shorter. But if you think about it, in order to see a drop in the albumin, it's going to take a few months, unless there is something going on in utero that was resulting in poor production of albumin. Glucose is also a good marker of liver function because the liver needs to make glucose or produce glucose. But remember, you could probably slowly kill off about 75% of your liver and still have a normal glucose. It's only when you reach that sort of critical mass that your glucose may drop. So you really have to have practically a dead liver to have an abnormal glucose. And also, you should send it stats so it's not sitting in the lab and the glucose drops. And the same thing goes with ammonia. That's why I have it in parentheses. Unless you can get a free-flowing blood sample sent to the lab, stat, on ice, don't trust the ammonia that you get. But in those babies where you have hypoglycemia, liver enzymes are abnormal, the baby's practically comatose, it is really important to get an ammonia at that point in time to look for liver failure. Hematology, looking at a CBC, looking for hemolysis, looking for a low white blood cell count that might indicate sepsis or a high white blood cell count. Looking at your platelets, which may be sequestered in your spleen if the spleen is enlarged. So if you don't think it's enlarged because the baby's crying and fussing and you can't really get a good exam, and you get a CBC and the platelets are 80,000, you know what, I go back and try to get a better exam on that spleen because maybe it's low, but maybe there are other reasons for thrombocytopenia such as sepsis. Bacterial infections, especially urinary tract infections, can be associated with cholestatic liver disease. But always check blood samples as well because urosepsis leading to blood sepsis is a possibility. These are sort of second round tests. An ultrasound is useful for looking for any anatomic issue with the liver. Serum alpha-1 antitrypsin would be reasonable to get, especially getting the phenotype because that's the most common metabolic cause of cholestasis in infants. Infectious serologies, if there is appropriate background information or lack of appropriate background information with maternal testing. If there are ascites, always get a sample of that fluid. And always go to your newborn screen. Every state has a newborn screen. The Ohio newborn screen has it screens for 32 different disorders, primarily of which, when we think about liver disease, amino acids, organic acidemia, CF, thyroid, galactosemia, those are the ones we commonly see on the newborn screen. These would be tests that probably you would be getting in consultation with your gastroenterologist or hepatologist, so I'm actually going to ignore these with regards to time. So question 4, 30-day-old infant with total bilirubin of 6.2 and a direct 3.2 milligrams per deciliter, enlarged hard spleen and liver. What is your likely diagnosis? A, Crigler-Najjar, type 2, B, physiologic jaundice, C, biliary atresia, D, Gilbert's. And C is the correct answer, I think. I see a little bit of A here, Crigler-Najjar. Remember, Crigler-Najjar is all unconjugated, so that's the most important. And in fact, all of those other 3 disorders should be all unconjugated. So since this is a conjugated direct hyperbilirubinemia, the only one left is biliary atresia. So biliary atresia, this is probably the most important thing, certainly a board question. That's a progressive sclerosing inflammatory process of the liver, leads to complete ductular obliteration with rapid end-stage liver disease if there's no means to ameliorate it. The pathology is here. If you could see, if I can work this is not a normal liver, okay? So if you want to know what a normal liver is, go to your grocery store, to the meat counter. Often they have, like calf's liver. That's what your liver should look like. If that calf's liver looks like this, don't buy it, It is not good. But it should be nice and smooth and homogeneous and pink. This is black, and actually that's sort of a greenish black, and you can even see the scar tissue developing all the way in between. And this is a cirrhotic liver that was removed from a 9-month-old with biliary atresia who underwent a transplant. Excuse me. On pathology, you can see these little bile plugs in there, and that's classic cholestasis. And then the other features on here, which is hard to see, but you can see these fibrotic bands going through here. And that also is classic for biliary atresia. There are 2 forms of it, but the most common form that you need to know about is a perinatal form, because that's really what the board questions are about. So you have that baby who comes in at a few weeks of age or 1 month of age. Perinatal form counts for 65 to 90% of the cases. It leads to complete obliteration of the fully formed ducts, late onset, like I said, a few weeks of age, initially maybe jaundice-free or maybe have a little bit of physiologic jaundice. When we do biopsies on these babies, they may have some bile duct remnants left, which means to us that this probably started in the acute perinatal period or shortly after birth. And then occasionally has an association with other anomalies. Just for your knowledge, the embryonic form, these babies come out with a direct hyperbilirubinemia. It accounts for 10 to 35% of the cases. They have minimal bile duct remnants because they are probably jaundice in the womb. And this is frequently associated with other anomalies because there was probably some insult that happened to the baby in the womb. The anomalies that are seen with extrahepatic biliary atresia include, they can occur singly or in combination, but they may include abnormal spleens with polysplenia, asplenia, cardiovascular defects with pulmonic stenosis, tetralogy of the Fallot, the same defects we see with other syndromic liver disease like Alagille, we can see with extrahepatic biliary atresia, abdominal situs inversus, intestinal malrotation, portal vein and hepatic artery anomalies. What about the outcome? Well, it's all about the timing. The sooner that baby is referred to a gastroenterologist or a hepatologist in a center where they can do surgery, the better. So in studies that came out, if you could operate on these children less than 8 weeks of age, there was an 86% success rate. Well, what does that mean? Well, that means that they were able to induce bile flow out of the liver into the intestines. The operation that's done for biliary atresia is called the Kasai operation. It's where they bring a roux loop of jejunum up into the porta hepatis of the liver, so that basically, you know, the bile ducts that the extrahepatic bile ducts that the baby has are all atretic, so they remove those, connect the intestine to the liver, and allow it to drain directly into the intestine, okay? So an 86% success rate. We attain bile flow. Is it long-term? It's possible. But I will tell you about 70% of these children will need a liver transplant by the time they're age 20. So what we really look for this procedure is, yes, to induce bile flow, and what that essentially does, it slows down the damage to the liver to get them to a bigger size or older age where they're better off being transplanted. Biliary atresia is the #1 cause of liver transplant, #1 cause of liver transplant in pediatric patients. If they operate on the baby at greater than 8 weeks, there's only a 36% success rate. But if a baby came to me at 10 weeks, would I say, oh, don't operate, the success rate is bad? No, I would say operate, because even if it was 20%, I'd rather get a little bit of bile flow to slow down this liver disease. The other key point is you need to have them done at a center which has done these before. And so there has been certainly shown that the centers that do more of these do better. Nutrition is incredibly important after biliary atresia, because if they do need a transplant, the bigger the baby, the better the recovery from a transplant. We also say vaccinate appropriately, because if they end up getting transplanted, we need to have them vaccinated against anything and everything. And then treating them as a normal child. I've had so many families, and I say this to you as caregivers because I've had so many families treat these children as those sick, ill children. They're special. They're put up on the, a stage everywhere, like, oh, And that's a disaster. These children need to be taken care of just like their other siblings in the family. They need to be disciplined, they need to be cared for and loved, and yes, they do have a problem, but treat them normally. Otherwise, when they're 10 years old and behavior wrecks, it's a mess. I put this here for your information, but these children, because they're cholestatic, they malabsorb fat-soluble vitamins. And those fat-soluble vitamins, A, D, E, and K, important for you to know, that's a board question. Deficiencies can lead to, I have them listed here, corneal damage, rickets, hypocalcemia for D, peripheral neuropathies, retinopathies, ataxia, ophthalmoplegia for E, and coagulopathies for K. So we give these babies massive doses because they don't absorb, they may absorb maybe 10, 20% of what we give them. So we give them 10, 20 times what they need. These are not the doses which you would give to a normal healthy infant. Because you can see toxicity from excess fat-soluble vitamins because they can be stored in the body and cause damage. So that's what we want to avoid. Other causes of extrahepatic cholestasis include choledochal cysts, or now known as biliary cysts, choledochal lithiasis, and spontaneous common bile duct perforation. I'll show you some of those. These are biliary cysts that we see. These are congenital. Sometimes they show up in the newborn period. They can actually even show up with masses in the right upper quadrant because the cysts can become very enlarged. But of note is that they can actually show up after a few years of age. And how do they present? They present with cholangitis because they have this cystic area. The bile kind of accumulates in there. You get one little bad bacteria in there, and then it starts growing and multiplying, and then you get cholangitis and an infection in that cyst. And so then they present with jaundice, fevers, right upper quadrant pain at 3, 4, 5, 10 years of age. We get an ultrasound, boom, we diagnose a biliary cyst. So something to think about. And this is an ERCP of a biliary cyst. This is a type 4A with intrahepatic and extrahepatic dilatation. You can see the cyst here, cystic dilatation, and here as well within the liver itself. Common spontaneous perforation of the common bile duct presents as an ill-appearing baby. It looks septic, acute development of ascites. If you were to tap that ascites, it would be green because the bile has leaked into the abdomen. They may have hepatomegaly as well. A HIDA scan is very useful in this because a HIDA scan basically does this, HIDA, the chemical, does the same thing that bilirubin does. So it's picked up by the liver, conjugated, then excreted. So if you did a HIDA scan, you would show this leak. You would see the HIDA radionuclide all throughout the abdomen. The treatment is surgical. They usually put not stents, a stent or a tube in the bile duct to allow it to heal, and then eventually that T-tube will come out. Idiopathic neonatal hepatitis, we still see this. Of all jaundice that we see nowadays, probably idiopathic neonatal hepatitis accounts for about 23% of it. There are sporadic forms, basically sporadic forms. We don't know what the cause of it is, but the good news is that most of those kids recover. But if there's a family history, that's where that family history comes in, of neonatal jaundice or deaths, and the baby was jaundice, those babies, 22% recover, 16% end up developing chronic liver disease, and 63% die. And this is still a group of that 23% that I told you about of all jaundice, cholestasis in infants, that we still don't have a good cause. It's probably some metabolic cause that we still can't determine and still working on. So question 5, 6-week-old was brought to the office by parents due to worsening jaundice, taking a hypoallergenic formula, and I put in here in the USA because I don't know what's in the hypoallergenic formulas outside of the USA, is maybe a little bit fussy. Our family history is remarkable for prolonged jaundice in some cousins, hypertension, and emphysema. Differential includes all of the below, but which one? So all except. A, galactosemia, B, sepsis, C, alpha-1 antitrypsin deficiency, D, biliary atresia. And this is a tough answer, but there are really clues in here. So when you think about it, the hypoallergenic formula, in the United States, all the hypoallergenic formulas either have glucose or sucrose, glucose polymers or sucrose. None of them have lactose. So therefore, this baby, and she's 6 weeks, so she shouldn't be getting anything else, like ice cream or cheese or anything else. So the likelihood of this being galactosemia is very unlikely. So the answer is A. Sepsis could be this because, the baby's getting a little fussier and now we suddenly have worsening jaundice and maybe not eating quite as well. Alpha-1 antitrypsin, the key in here is that I told you that family members have emphysema, and alpha-1 antitrypsin deficiency can present usually in the newborn period or in childhood with elevated enzymes and jaundice, but later in life can present with emphysema, especially if the patient is a smoker. And biliary atresia, she's 6 weeks old, right in their right age range. So I would think that, in my opinion, the correct answer would be galactosemia. Neonatal alpha-1 antitrypsin, liver disease is primarily associated with the PIZZ phenotype, so that's why it's important to get the phenotype. Inheritance is autosomal co-dominant, so that's why you need ZZ. An MZ phenotype, M is the normal phenotype for alpha-1 antitrypsin. If you had an MZ person, they're not going to have liver disease. It's not enough to cause damage. But if you have a ZZ or a Z null is where null is that they actually don't even make the alpha-1 antitrypsin. The Z is an abnormal protein. It collects in the liver, causes damage, and so Z is the bad dog in all of this. Only 15% of ZZ develop liver disease in the first 20 years of life. If it's present in the neonatal period, 50% develop micronodular cirrhosis. So it's a common cause, and we've transplanted many kids with alpha-1 antitrypsin deficiency. Other causes of neonatal cholestasis include the ARC syndrome. I put that in there because it's something to think about: neurogenic arthrogryposis multiplex, renal tubular dysfunction, and cholestasis. Paucity of the intrahepatic bile ducts, you can have a syndromic form, which is called Alagille's, we'll chat about, and non-syndromic form. And then we have various progressive familial intrahepatic cholestasis. FIC1 is deficiency, previously known as PFIC disease or Biliary syndrome. You may have seen that. It's associated with Amish kindreds. And then there are other PFIC, progressive familial intrahepatic cholestasis syndromes associated with other deficiencies. And now we think there are at least 5, possibly 6. Paucity syndrome, syndromic form is Alagille's. It's autosomal dominant, but it's incomplete penetrance. So you could have a parent of a child who has this, the parent could have features, some of the other features, but not all of the features of Alagille's, and the baby could have all of the features or primarily just the cholestatic features of it. The anomalies that are associated with it is posterior embryotoxon. You need an ophthalmologist. I can't see it to see this. It's present in over 95% of the kids with Alagille's. Heart defects, the classic one is pulmonic stenosis, peripheral pulmonic stenosis, but you can have pulmonic stenosis and tetralogy and flow and a whole grab bag of other heart defects. Skeletal vertebrae, you can have butterfly vertebrae, and I actually had one referral from a radiologist who was doing a chest x-ray on a young child who had congenital heart disease, and he's looking at the vertebrae, and he calls me up, and I wish I could do his accent. He was from South Africa. And he says, Vera, I think this child has Alagille's. He has pulmonic stenosis and he has butterfly vertebrae. And sure enough, he got referred to me and we diagnosed him with Alagille's. And actually his liver disease did very well. Renal anomalies include interstitial nephritis. Facial anomalies include a prominent forehead, hypertelorism, flattened malar eminence, a pointed chin. People think they look somewhat elfin looking. That's when you look at the families, because a lot of times these children kind of evolve into these faces. There's some issue that people think that this actually might be a more normal faces for children with liver disease, so it's hard to say, but they often do have this very characteristic feature. And mental retardation can be associated with it, but it's most commonly associated with nutritional deficiencies and delayed because of illnesses. The prognosis, 17 to 28% die due to either their liver disease or their cardiac disease. Liver disease is present in about 95% in the first year of life, so it's very common among these children. Survival post-transplant is only about 75%, which is much less than the expected over 90% survival with other liver transplants, say for like biliary atresia, and that's most probably because of the associated heart disease with these children as well. And as I said, autosomal dominant with incomplete penetrance. There's non-syndromic paucity. So what is bile duct paucity? Is if I did a biopsy on you, you should have at least one bile duct per 2 portal triads. So like a half a bile duct per portal triad. That's a minimum that we want, and we need to look at 10 portal triads to make that definition. If you have less than that, that's bile duct paucity. And if you don't have those other syndromic findings, you think about a non-syndromic form. And it can be associated with basically anything and everything. So diagnosing bile duct paucity without the other syndromic findings doesn't help you. You still have to look at the whole grab bag of things that it could be associated with. Progressive familial intrahepatic cholestasis. These children usually present with pruritus, poor growth, steatorrhea, progression of cirrhosis fairly rapidly. Most of these disorders have a low or normal GGT, so that's kind of the classic finding. The only one that's associated with a high GG is the PFIC3, which is the MDR deficiency. Diagnosis is based on the labs and bile duct and sort of biopsies. The thing that's important to know is gestational autoimmune disease, which formerly was known as neonatal hemochromatosis. This is the most frequent cause of acute liver failure in newborns. It's usually associated with intrauterine growth restriction, oligohydramnios, so this is happening in the womb. Iron ends up being abnormally distributed in the liver and in extrahepatic tissues like the heart, the adrenals, and the pancreas. Biochemically, they have a very high ferritin, greater than 800. They have a very high alpha-fetoprotein, greater than 200. And in fact, alpha-fetoprotein, which is associated with hepatocellular carcinoma, can actually be found in these babies at presentation. They present with severe liver dysfunction. So they're not making glucose. They're cholestatic. They're not able to they're able to conjugate their bilirubin, but it's not able to get out of the liver. They have synthetic failure. Their coags are abnormal. But what's unusual about these children is that they have a lower absent ALT and AST, and it's probably because necrosis doesn't seem to be a big component of this disorder. So if you have a low enzymes and the liver seems to be dying because it's not making the stuff it's supposed to be making, you need to think about gestational autoimmune liver disease. Treatment is, if you've diagnosed it in the womb, inadvertently we did diagnose it on one mom who had an MRI for one issue or another. They found abnormal distribution of iron in the infant, in the fetus. We were able to make that diagnosis earlier, and we were able to prepare for that infant. If the baby is, and then the other reason you would know this is if the mother had a previous baby who died of neonatal liver failure, you have to have a very high suspicion that the next baby is going, well, actually probably over 90% chance that the next baby is going to have the same thing. So you need to pre-treat that mom with any subsequent pregnancies with high-dose IVIG. Infants, if they're born with it, we used to give a antioxidant cocktail. Now we give high-dose IVIG and exchange transfusions, and the recovery is better than it used to be, but still, if they do not recover and they are in liver failure, we would start the process for an acute transplant. Drug-induced liver disease can be associated with chloral hydrate, drugs that pass through the maternal breast milk, furosemide in those children who have heart disease, antibiotics that you're using for sepsis. So always think about drug-induced liver disease. Always think about vascular causes. Neonatal asphyxia is probably the most common thing we see. Post-op ischemia is one of the common causes we see for elevated enzymes and cholestasis. And sometimes in those babies, the enzymes go up first, the enzymes start coming down, and you think everything is hunky-dory, and then the bilirubin starts rising. That's the normal progression post an ischemic event, okay? So you need to watch it carefully, make sure the enzymes don't start rising again and other things, but that's not uncommon. Budd-Chiari syndrome is rare, but it can present with outflow obstruction from the liver, so you're going to get hepatomegaly, splenomegaly, ascites, and jaundice. Veno-occlusive disease, otherwise known as sinusoidal occlusion disease, and neoplasias are rare in infants. Metabolic disorders are very common. Be a good detective, especially with the carbohydrate disorders, in the lipid disorders or the amino acid disorders. There may be a family history. Some of those things are going to be picked up on the newborn screen. The carbohydrate disorders, the only one that's on the newborn screen is galactosemia. Fructosemia, if the baby starts developing jaundice at 6 months of age or 3 months of age, and you get the history, well, we just switched formulas from cow's milk formula or from breast milk, which is all lactose, to a formula that contains sucrose, and the mom's not going to tell you this, you have to realize this. Or we just started on Karo syrup and some other things, and now the baby is jaundice or starting to go into liver failure. Think hereditary fructose intolerance as a cause. Glycogen storage disease as well can lead to newborn cholestasis. And then other metabolic diseases, again, many of these things picked up on your newborn screen, so be aware of it. And never, ever forget, Dr. Sabello tells me all the time, to think about viral and bacterial causes as well of cholestasis, because these babies have immature immune systems and they're at very high risk. Thank you very much.